Shah, and I come from Rutgers University, New Jersey. I would like to thank the chairs for my introduction, and I will try my best to keep my talk engaging and interesting. So, though I am an anesthesiologist by profession, when it comes to airway management, we share this skill with many other specialties, and one of them is the emergency room personnel, one and very important one, actually, I should say. So, no conflicts of interest. I'm going to start with the case. As you see, my first slide was about, there was a picture of LMA and there was a picture of I. My talk is going to revolve around airway management, but I would like to take this case as an example, and so that we can understand the gravity and the importance of how important it is that when it comes to the airway. So this case, I had the opportunity to perform an anesthetic on a few years back. It's a 8-week-old girl who was born at 36 weeks gestation with a very low birth weight of 4 pounds and 3 ounces. So was found to have about 4 weeks of age, a left eye discharge without any other significant findings. So at 5 weeks, the mother noted bleeding from the medial corner of the left eye with some swelling on the lateral aspect of the eye. About 6 weeks, mass became very protruding, became friable, and the needle aspiration was performed at the referring center, which caused mass to start oozing more. So soon after that, the baby was scheduled for an elective excisional biopsy of the mass. When baby showed up to the hospital, the preoperative anesthetic interview, what we found was history of low birth weight, an NICU stay for the poor feeding, but otherwise non-contributory. So we did not have any formal pediatric clearances, but there was a most recent history and physical by pediatrician on the chart. As per that, the baby did have an echo at birth, which showed no congenital cardiac issues. The genetic test was performed at birth in the view of low birth weight, failure to thrive, low set ears, and slight micrognathia. On examination, the baby did have some current URI, some runny nose, but no fever. The chest was clear. There was a lot of tachypnea and somewhat distressed and pale-looking baby. Decision was made to establish the IV preoperatively, which we almost routinely don't do for an elective case. We always have it post-induction. But also the blood samples were taken to check out the hemoglobin and sent for the type and cross, thinking about future need for the blood transfusion. So obviously the risk ahead were, which were expected ones, were some hemodynamic instability. Of course, airway is always a concern, even though that slight micrognathia was not very much appreciated at the time and was not considered as of to pose too much of difficulty. We do expect problems with oxygenation and ventilation when it comes to the littlest ones. And the post-op management in terms of requirement for post-operative ventilation and hemodynamics. So, yes, the challenges in the operating room did involve a lot of lability of the vital signs, difficulty mass ventilation in the view of that a friable tumor, which always was in the way of having a mask feed. So direct laryngoscopy, when it was attempted, it revealed a grade 3 Cormack-Lehen view of the glottis. That means the intubation was very difficult. We were not able to intubate with the direct laryngoscopy. Also, it was because of rapid desaturation during the time that we were not ventilating the baby and attempting the laryngoscopy, which also limited the time to laryngoscopy. So also, then we switched to our next device after the direct laryngoscopy was the glide scope. And with the glide scope, we were able to see some part of the glottis, but an intubation was performed. But what was happening was it was very difficult to detect the end-tidal CO2. While waiting to have end-tidal CO2 on our monitor, the desaturation was happening very quickly, and we had to make a decision to remove the endotracheal tube and continue ventilation, which was a better option. So at some point of time, we decided to abort the laryngoscopy efforts, and LMA we decided to use an LMA, the next thing. Now, the RQ LMA, which was a relatively new introduction at the time, this is the year 2012 about. So we decided to use the RQ LMA, see how it fits. And also we had heard of that is an intubating LMA, so possible future, help may also be possible. So our LMA insertion was very adequate. We were able to ventilate the baby very nicely. So we decided to deepen the anesthetic with the LMA because it was also giving a hands-free technique and giving us some break time. So later on, we attempted the blind intubation through the LMA, and which was really successful. And we were able to detect confirm the endotracheal intubation rather. So this is the device that I used, and at this time, I'm sure a lot of people are aware of this device, but in 2012, it was a new introduction. The most important part, on the top, it says the color-coded blue connector. That connector comes off. How does this turn off? Here. And then the intubation can be performed. Also, there is an integrated bite block. It gives a facility for the gastric suction. So this is how exactly the tube passes through the LMA and situates itself. The challenge that happens after inserting the endotracheal tube and confirming that we need to remove the LMA. So at the time, now with the RQ LMA, there is also another device called pusher, which you attach to the end of the endotracheal tube and make a channel longer and remove it over the LMA. This is how it is usually removed. But at the time, we did not have the pusher. We had to put a one size smaller tube at the end of our original tube and create a longer channel, and we were successful in removing the LMA over the tube. So what happened to our patient? The histopathologic exam, it did come up. The final report was a hemangioperistoma of the orbit, and she was found to have a trisomy 15 also. So what does it mean to an anesthesiologist? Besides having all this histology and findings and all that, the more important to me was that it says that it's a recurrent lesion, can have a more malignant course, and can metastasize. What it tells me that I'm going to see this baby more often in the operating room in future. So now I'm going to switch to review some of the airway aspect of the how to use the LMA and the devices other than the routine, the conventional laryngoscope. So this is the anesthesiologist's dream. When we do the direct laryngoscopy, this is what we like to see. That's the central wide opening of the cords, tracheal lumen, epiglottis in the anteriorly, above that the tongue, and the posteriorly is esophagus, and laterally the vestibular folds. So this is a slide about how we evaluate our airway preoperatively and intraoperatively during laryngoscopy. The first four upper figures are about the Mallampati classification. So class 1 airway by Mallampati is you visualize the four structures, which are the uvula, the pillars, hard palate, and the soft palate. As you go forward from class 1 to class 4, the class 4 is the very extremely difficult airway where you only see the hard palate. Class 3 is you do see some part of the soft palate, but nothing else. And the below four figures are about the Cormack-Lehan view, which is the view when you perform the laryngoscopy. So it doesn't really necessarily correspond to the Mallampati views of evaluating the preoperatively. So it has its own significance and implications. Grade 1 is very much, you see the full view of the glottis. The grade 2 is almost the full view, just a little bit constricted. The grade 3 view is visualizing the epiglottis, and grade 4 is seeing nothing. So if you have a grade 3 or 4 view during your direct laryngoscopy, it actually alarms you that now you should switch to the next device. Think about switching at least. So, and the Mallampati classification is best performed when the patient is sitting upright or standing with the face-to-face level rather than patient in the bed lying supine and you are overlooking. So this is the glide scope view. This is the device we had used initially. I just want to show you that's how it looks. You see the glottic and supraglottic structures with the, this is an indirect laryngoscopy. So I will just review some of the differences between the adult and pediatric airway. I have articles on the bottom of the slides, which are great review articles. This one is by the Lola Adivel, which was published in 2009 in Pediatric Anesthesia. So I would say the key differences between the pediatric and the adult airway are infant larynx, more cephalad in the neck, as you see in the first, on the left corner. It usually is at the level of the C3, C4, up to 2 years of age. And the adult larynx at the level of C4 to C5. And adult epiglottis is very flat and broad with the axis parallel to the trachea, whereas the infant epiglottis is narrower, omega-shaped, angled away from the axis of the trachea. So that difference makes it a little bit difficult to visualize with the tip of the blade. So recent studies have shown that the similarities in anatomy of the pediatric and adult airway, and they say that the subglottic area to be the narrowest part in both the age groups. And if you see both the infant and the adult airway, they both are more or less funnel shaped, but the shape is a little bit more exaggerated in infants and children. So what is the best position when you want to intubate anybody? These are on the top, the three pictures are about the three different positions that you can imagine. This one is the flat on the bed. The one in the middle is the head is extended. And the first picture is typical sniffing position. That is considered to be the most ideal position for intubation. And I would say that the proper positioning of the head and neck in patients undergoing direct laryngoscopy is an important step for successful endotracheal intubation. The improper positioning can lead to prolonged or failed intubation attempts because of the inability to visualize the larynx. Sniffing position is defined as the elevation of the occiput and extension of the head at the atlanto-occipital joint. It is generally accepted as the best position for direct laryngoscopy. There is also a two-curve theory, which is right here, being a primary and the secondary curve. So primary curve being the oropharyngeal curve, and the secondary curve is pharyngoglottotracheal curve. So, so the two-curve theory consists of when the head is extended, the primary curve basically flattens. And when the laryngoscopy is attempted, it actually completely flattens the primary curve. So, but the sniffing position flattens both the curves. So a standard definition of sniffing position is that the neck should be flexed 35 degrees on the chest and the head extended at the atlanto-occipital joint, 15 degrees. So also there is one more position which is popular, is the ramped up position. And ramped up position is usually recommended for the morbidly obese patients. The ramped up position in morbidly obese patients provides the ease of ventilation and a better glottis view than the sniffing position. So the article by the Greenland from 2010 is the MRI evaluation of the position configuration. So I'm going to just take a look at the algorithm, the ASA, the American Society of Anesthesiologists, difficult airway algorithm, where the laryngeal mask airway has its place in at least 5 different areas. So when it comes to difficult airway, it could be recognized or unrecognized. The recognized difficult airway can, again, can be managed with a lot of preparation, or you can have a recognized difficult airway in an uncooperative patient. So we will go that path later, but recognized airway, which is a difficult one, and have been prepped well, has the choices to do awake intubation, and where LMA comes in view is like, it can be used as a conduit for a fiber optic intubation. So the next path is when you have an uncooperative patient, or it is an unrecognized difficult airway and general anesthesia is already induced, you have to worry about 2 different paths again, that you have an easy time with the mask ventilation versus you don't have the easy time with the mask ventilation. If you cannot even mask ventilate, it basically becomes an emergency pathway where LMA has a place where you can place the LMA and use as a ventilatory device. And if you have a success using as a ventilatory device, you can further use it as a conduit to fiber optic intubation. Or if you have an easy time mask ventilation, then again it becomes a non-emergency pathway where you have intubation choices. Again, the LMA as a fiber optic intubation conduit. Or if it fails, you can at least use an LMA as a ventilatory device, and you can make your decisions about either you wake up the patient or continue LMA and use this as an intubation conduit. So there are a lot of choices. The more difficult algorithm is can't ventilate. Very, very, very rare in scenario in a real life, because we always want to make sure before we make the patient apneic that we can ventilate. But if it happens so, what you do is you do your basic maneuvers, reposition the head, put some simple airways, do a cricoid adjustment, and if laryngoscopy was not performed, then it should be done. And after all these maneuvers, you have two paths. You can ventilate and oxygenate. Of course, you wake up the patient, or you continue with your airway choices. And if you cannot ventilate after all those basic maneuvers, then LMA again comes in the picture where you can have a ventilation success. If not, the cricothyrotomy remains the last resort. So what are the LMA devices available these days? Tons of them, actually. So you have an AMBU, you have a Supreme, you have iGel, ProSeal, RQ, and LMA Flexible. These are just, so the history of LMA goes back to 1988 by Dr. Archibrain, who introduced the first supraglottic airway device, and he took the idea actually from the Goldman Dental nose piece. And the history actually goes back a lot further. 1788 was the first time the tracheal intubation, and after that, the era came where up to the 1968 was different varieties of oral airways were invented. 2000 was the first reusable, 1981 actually was the first human use of the laryngeal mask, and 2000 is first reusable second generation supraglottic device, and 2003 to 2010 has been all those varieties of the second generation LMAs have been introduced. So what is the difference between the first and second generation LMAs is first generation is basically just the airway tube, serves the basic purpose of ventilation. The second generation LMAs have a lot more functions. They have a gastric suction channel, they have improved pharyngeal seal, and they have an integral bite block. So these are the first generation, the few first LMAs which were in the practice. The one is the LMA Classic. Is a first generation, is a versatile, reusable airway with aperture bars used extensively. So LMA Unique is a single-use airway. This comes in a packaged, sterile, and ready for use, and it is more suited for device where it is like emergency room settings. So Jagannathan has a lot of contribution to the research on LMA, and these are the two very good articles from him. Then he came up with the recommendations that despite the many new devices, the laryngeal mask airway ProSeal and the LMA Unique remain the most ubiquitous devices in the pediatric use, and it still provide excellent condition in a wide variety of situations with only a few specific exceptions. LMA ProSeal, RQ, and iGel may be preferred for their stability during anesthetic maintenance. The LMA ProSeal and iGel have higher airway leak pressures, and so may be preferred during positive pressure ventilation and gastric access. And the RQ and the AMBU IORA are designed for the endotracheal intubations. So these are the intubating LMAs, mostly used in operating rooms. Wrong statement actually. I have seen EMS bringing patients with the intubating LMA in place, tube in place, they are not able to remove the LMA over the tube, so they bring the patient to the emergency room with the LMA basically the fast track is very popular for the emergency usage. Have seen patients coming with those. So the LMA Fast Track is an intubating LMA designed to serve as a conduit for intubation. Although most LMA designs can serve this purpose, the LMA Fast Track has special features that increase the rate of successful intubation and does not limit the size of the endotracheal tube. So these features include, it has an insertion handle, which is right here. It has a rigid shaft and with anatomical curvature and an epiglottic elevating bar to lift the epiglottis as the endotracheal tube passes. So iGel LMA has a soft, gel-like, non-inflatable cuff designed to provide anatomical impression fit over the laryngeal inlet, and the shape and the softness and the contour accurately mirror perilaryngeal anatomy. This mask has been very popular in Europe, I'm sure in America also it has been used, but at our institute we rely a lot more on the RQ LMAs. So the RQ intubating LMA is a new supraglottic airway, is approved for use as a primary airway and as an aid for intubations in situations of anticipated and emergency difficult airways. So the unique feature of this device as compared to the other airways in the market is the size of the inner diameter and the length of its airway tube. It can allow up to 7.5 millimeter internal diameter endotracheal tube through the lumen. So that's the best advantage of the LMA. Overall, the silicon-based LMAs offer less resistance to the passage of the endotracheal tube than the polyvinyl chloride-based LMAs. It does become a challenge. It's not very impressive to see the rate of successful intubation through the intubating LMAs is about 70 to 80%. It's not just 95% or 99%. So it does need some expertise. So the LMA ProSeal and the Supreme may be used as conduits for tracheal intubation also, but their narrower tubes preclude the ability to directly pass the adequately sized tracheal tube to these devices. So the airway exchange catheter and other devices may be needed. So this is about the intubating LMAs. This is the incontinuity of the intubating LMAs. That these are the two articles. One is by the Pandya et al. In 2015. He did the evaluation of the glottic view through the RQ intubating LMA, and as per this research, the best glottic view is always with the RQ LMA compared to other LMAs. And he also assessed it for the blind endotracheal intubation device in children. And the similar study was done on the iGel by Geeta Bhandari, studies from 2013. So I will review some of the devices besides the LMA, devices which are alternate to direct laryngoscopy. So LMA C-Track, very popular device for emergency purposes. It's very portable, and it is basically the LMA fast track with the attached screen on it, so you can visualize what you are doing, and it gives a better view and the better approach to the airway. So that's the LMA C-Track. And there is a good study on LMA C-Track from 2006 by Liu from the British Journal of Anesthesia. These are all the devices available in the market, alternative to direct laryngoscopy. This is pretty much direct laryngoscopy, just the flex tip. So flex tip basically used to lift the epiglottis, which could be in the way. This basically is the LMA, intubating LMA, the fast track. This is the glide scope, the McGrath, and air track. Air track, yes. Basically, it has a built-in channel for the tracheal tube, and it's available also in pediatric sizes. Used successfully in the children. The drawback of it is it's hard to use in small infants because it requires a little space in the mouth, which may not be available on little babies. And it usually directs the tube leftward, requires the manipulation of the device as a unit to help guide the tube in the trachea. So it can be used as a bougie or in combination with the fiber optic bronchoscope when there is a difficulty passing the tube. So the glide scope and the McGrath video, there's a nice comparison study on the McGrath and the glide scope by the Wu J. Kong. It's a 2011 ASA. Basically, the glide scope has a video baton that inserts into a disposable plastic sheet, and it can be used in all age groups, associated with the better glottic views when compared with the direct laryngoscopy. So the laryngoscopy should visualize the tube throughout its advancement. It's very important because there are lots of reports of damage to the soft palate, to the gum mucosa while trying to blindly insert because you are so fixated on the screen. Rather, McGrath is a handheld device and the design similar to LMSC track and is useful as a portable device being small and lightweight. So this picture is the most recent is a CMAC stores. CMAC comes with the advantage over GlideScope is CMAC also offers is the straight blades, which are more popular in pediatric practitioners. So, and its blades are also the Mac and the Miller designs. So I would say that intubations using GlideScope and CMAC stores have a very comparable success rate. There are few fundamental design differences between the GlideScope video laryngoscope and the CMAC devices. The GlideScope is designed with a hyperangulated blade. This design often requires the use of a specially shaped stylet. The hyperacute blade curvature prevents view by direct laryngoscopy approach, so it cannot be used for direct laryngoscopy. However, the GlideScope may be useful in situations in which it is impossible to align the oral, pharyngeal, and laryngeal axis, where it comes the morbid obesity and also the tongue swelling situation, pharyngeal obstruction, and the C-spine immobilization. So on the other hand, the CMAC resembles a traditional Macintosh blade right here, and it allows the laryngoscopy to be accomplished by either the direct laryngoscopic or indirect video visualization. So that is the benefit of CMAC over the GlideScope. So this is the study that confirms what I just told you. The study 2013 by Mosier for annual emergency medicine, and the 2012 the study is a comparative study of the GlideScope, CMAC, and the Macintosh laryngoscope, but it's a mannequin study, so it doesn't have a lot of value. So these are the two very important devices I like to go over, the King laryngeal tube airway and the Cobra tube. King laryngeal airway has been used a lot by the EMS personnel. They both are very easy to insert, and most studies have shown a very high success rate at the first attempt, and it also provides a very high seal pressure, so it can also be used as a ventilation device, and also in the emergency settings. Very easy to insert and manage. And there are two very good articles on that. So these are the pictures of recognizable difficult airways, one being the cleft palate. You see the morbid obesity, Pierre Robin, you see the golden hair, and see the severe hydrocephalus, and of course, trichocolins. So what we do? So we can divide the predicted difficult airway in three categories. The one is the hypoplasia of the mandible, second is the hypoplasia of the midface, and third is the macroglossia. So hypoplasia of the mandible, typical presentation is the trichocolins, Pierre Robin, Marfan, D. George, and Cre du Chat. With the midface hypoplasia, the Carlson syndrome, the Epper syndrome, Pfeiffer, Marshall-Stickler, and achondroplasia. The macroglossia is one with the Down syndrome, with the Bakavich impediment, neurofibromatosis, cretinism, and amyloidosis. So we have a lot of predicted difficult airways out there, and also we have a lot of unpredicted difficult airways there. So lastly, I would say that esophageal intubation is not a sin, but we should avoid it all the way when as far we can go, and so that the research into is also very rewarding. Having a newer and newer devices, it does keep our hands-on experience and our training good. And so this is my workplace, and I'd like to thank you all for listening. And any questions? Yes.
I actually have two questions. Question number one is, maybe you said that, but when you started the induction? Was it an IV or inhalational induction? Did you already have an IV at that point? Or
Yes,
was the sequence?
Yeah, I did mention we decided to place the IV on this baby because looking at very sick looking, pale, I see the mom is holding a gauze on the eye and expect some, at least it was over the weekend that time was spent without, mom's knowledge that she needs to have a, like she should seek attention. She did not realize that. So we decided to place an IV. We wanted a preoperative lab, so we sent the hemoglobin and we sent for the type and cross. So,
and
yeah.
then you used what, propofol? Or?
So what I did was combined very slow, very gentle induction with the combined IV and inhalational. So I tell you the truth that micrognathia was not very appreciable. In a way, we might have missed it also a bit because looking at the gravity of the situation, this baby was scheduled to be done as an elective case. When we called at 6:30, we called, they didn't show up until 10 a.m., so we called home that what is happening, are you coming? And the mom said that, oh, I fed the baby had a feeding at like some few hours before. So I said, how is the baby doing? I said, the baby has a little bleeding now. I said, we need to come. You need to come today. So, and she showed up, and good that she showed up. This elective case really became an emergent, scheduled in an ambulatory center. We moved to the hospital right away. And we started preparing, recognizing I was impressed with the low set ears, and also I was expecting I could have a difficulty with the airway. Knowing the other history, we were prepared for difficult airway. But the more difficult was, I think we had intubation with glide scope, but detecting the intubation with this acute, with limited time to maintain the oxygenation, and you cannot really wait. You can hear the breath sounds with all the other extra sounds that you expect in URI child. It was very difficult to detect the intubation. Yeah.
One last question, since I think we have to move on to
Yes.
is, so it's next Monday morning, okay, and you see the same patient again. Would you do anything different? And if so, what would you do, or what would be your...
Yes, so this baby came back twice, actually. The baby actually ended up a week later, another mass showing same eye, needed an MRI. So we had the challenge right there, so we intubated the baby in the operating room and brought baby downstairs for the MRI. And after MRI, baby was scheduled for another surgery. But all those times, I did not have the challenge of acute URI, hypovolemia, low hemoglobin. Baby's hemoglobin was 6 grams at the time of the first surgery when we received the labs back. Yeah, ended up receiving blood transfusion and everything. So, but all other times, relatively healthier baby and more preparation, we were able to intubate with glide scope all other times. Yes.
All right, very good. Thank you.
Thank you. I'm sorry, which scope? Ambu. I haven't heard. No, we don't have endoscope. What is the difference?
So what the endoscope is more like when you're exchanging tubes.
Uh-huh.
So you can put the actual fiber active tubes down. So it's actually a fiber active.
Fiber optic.
Yeah.
Okay. Yes, I know there are a lot many more devices out there, but I picked the most common, and yeah. Have you used iGel? Yeah.
Our anesthesia team have a difficult airway cart.
They come.
All the equipment is on there, so it's like each cart is like a $10,000 cart.
Yes. Yes.
I mean, it's nice to play with these toys, and I totally love it, whether it's the fast track or whatever. In my opinion, at least, or the glide scope, if you have a truly difficult airway, what I've come across is that those glide scopes or video laryngoscopes, they very, very often give you a very good picture, whether you see through it or you see it on the actual screen. What tends to be then more difficult is if the larynx is really anterior flexed to actually get there. So what you sometimes in those event Cs, you have this, the image, and then you see your endotracheal tube coming usually from the right lower corner, right? And here's your trachea. And if you have like a resident or nice to learn and to figure out and to use, but I think, I mean, in the end, if you really, really need to rely on that, you know, I mean, I think then there's nothing that really goes beyond, you know, just your fiber optic, even without the tower, you know, just as you go. And I talk with other colleagues, I don't know what your opinion is, but, you know, you sometimes get an awesome optic, and the actual handling might be more difficult than what you see.
For me, the glide scope and the CMAC are always a backup device because the looks are deceiving. You can see everything so perfectly or you just can't intubate.
Yeah.
I have been through those situations, and I have other 4 anesthesiologists in my room, and we have to abort the glide scope, CMAC, and then the gold standard fiber optic through the nose drill. That's what we perform at the end.
One last
So.
thing is, though, with the difficult intubations where the patients are rapidly desatting, what we've actually had in the past is as you have a glide scope in and you're looking, someone actually stands to the side and the glass goes through down the side, and it keeps you sat up long enough for you to actually get enough time to get the tube in. And so that's something that I don't know if you know Dr. Avery Tom, but he and I are doing a study on that.
Uh-huh.
He's one of the leading doctors.
Yes, the time factor is the big one that, you know, limits your efforts, and yes.
It's so simple.
All right, guys, thank you.
Thank you.
Speaking about the time factor,
Yes.
so Chris